Thank you, Madam Chairman, for your introduction, and also to the organising committee for inviting me here to this absolutely gorgeous place. It's too good for a conference. Why do we want to work when there's beautiful sunshine, the sea and so forth, and we're all here? Thank you for coming. I'm going to really sort of extend some of the concepts that you've heard from the first two speakers into a more general area of psychoimmunology. I must say the first speaker missed a very, very important antioxidant, red wine. The problem with red wine is the major ingredient is resveratrol. In order to get a pharmacologically significant amount of resveratrol to be an effective antioxidant, you have to drink 12 bottles of good red wine a day. I think that's a problem, but it's worth trying. Right, I'm going to start by giving a very brief overview, which you can see here, and I'll be covering, or try and cover, most of these topics in a rather superficial way. But really, going back to what my colleague, Dr. Mient, was saying, we have to look, I think, in a much more holistic way at depression and how antidepressants work and how psychotropic drugs work. And this is where I think we have a big advantage in looking at psychoimmunology as a sort of a new concept. And then go on and talk about chronic low-grade inflammation. We're not talking about infection. We're not talking about the consequences of a bacterial or viral infection, which we know will cause what we generally call sickness behavior. We're talking about chronic low-grade infection, which may last for many, many years and have major consequences in terms of brain function. And then talk about the link between chronic low-grade inflammation and depression and the consequences, the possible consequences of this. What happens when you have chronic low-grade inflammation present in the brain for many, many, many years? Somebody becomes depressed as a teenager, as an adolescent, and when they get to age 70 or 60 or 70, what happens to their brain as a consequence of being exposed to these inflammatory mediators for so long? So those are the sort of areas. This is my favorite person. It's not me, it's Hippocrates, actually. So when you go back 2,400 years, really the first, in my opinion, real neuroscientist was Hippocrates. Because when he started to look at human disease, what did he talk about when he was talking about depression? He was talking about melancholia. He was talking about a mental state, depression being a consequence of an excess of black bile. In other words, there was a chemical basis. Now, many of us think that possibly that chemical basis could be one of these end products of the kynurenine pathway that you've just heard about from Dr. Mient. But it was Hippocrates that really laid the basis to what I would consider the modern thinking in biological psychiatry that got lost with all this sort of Freudian nonsense and theological thinking during the Middle Ages and until recently. So looking holistically at this is a sort of diagram you've seen on many, many times, showing the interrelationship between external stressors, changes in brain function, including the corticotrophin-releasing hormone or corticotrophin-releasing factor, which has profound effects in initiating an inflammatory cascade. As I say, we're not talking about an infection, we're talking about a psychological stimulus leading to an inflammatory cascade, which then has consequences in terms of other areas of the brain and particularly in terms of the immune system. So we're really talking about an interrelationship between the brain, immune system, but also the immune system and the brain. So there's a complete interaction between these processes, which forms part of the stress response, which certainly forms part of all major psychiatric disorders, and as a consequence of that, means that the immune system is a fundamental part of all psychiatric disease processes. And so when we actually look at depression, we conventionally just think of this in terms of a disorder of monoamine metabolism, particularly serotonin and noradrenaline. Of course, we're not saying that those neurotransmitters are not involved. What we are saying, however, as you've already heard, is that it's much, much more complex than that. Besides the oxidative stress, which we've already heard about, and the low level of antioxidants, so we have mitochondrial damage, which is a profound effect, therefore, on energy balance, changes in the immune pathways, increase in inflammatory pathways, which you've already heard about, and what we call neuroprogressive pathways. In other words, the neurotrophic factors, which again appear to be affected, profoundly affected, as a consequence of chronic long-term inflammation. So all of these and many other components are important aspects of the pathology of depression. So what's the actual evidence then? What's the clinical evidence? Again, I'm not going to talk about the experimental evidence, which backs up many of these points in much more detail. But if we actually look at the clinical evidence of an increase in inflammatory biomarkers in depression, there's a whole number of these biomarkers involving both the cytokines, the pro-inflammatory cytokines basically increasing, the anti-inflammatory cytokines decreasing, the inflammatory chemokines increasing, soluble receptors, many of these are decreasing, so they can't counteract the adverse effect of the increase in the pro-inflammatory cytokines. And then we have other markers of particular interest, which we'll hear more about in the last talk, is the prostaglandins, prostaglandin E2. And the whole prostaglandin cascade is very important in all major areas of psychiatry. So all of these play a very important part in the psychopathology of depression and indeed other major psychiatric disorders. Now, the concept of the psychoimmunology of major psychiatric disorders has really been around for quite a long time in the 1960s and the early 1970s. But the really important concept, I think, was brought out by Ron Smith, an Australian psychiatrist, in a publication in 1961, which he called the macrophage theory of depression. And he postulated that many of the changes that we see in major psychiatric disorders, particularly depression, were primarily attributable to an increase in pro-inflammatory cytokines. At that time, of course, our knowledge of the immune system in psychiatry was rather poor, but nevertheless he gathered together all of the evidence, clinical evidence then available, to support this hypothesis. Now, needless to say, like all new hypotheses, this was totally and utterly disregarded, and many of us working in the area at that early stage never got any support at all from medical research councils and so forth, because psychiatrists said the immune system has nothing to do with the brain, and immunologists said there is no immune system in the brain, so therefore these guys are completely crazy. However, unfortunately, we were right. And this just summarizes the sort of evidence which initially Ron Smith brought forward. And what was even more important, he could show that a depression-like symptoms could be induced by these pro-inflammatory cytokines when they were used therapeutically, for example, to treat hepatitis, drugs such as interferon. So here we have two situations. One, where you could induce depressive-like symptoms with pro-inflammatory cytokines in otherwise non-psychiatric patients. On the other hand, if you take untreated patients with depression, you could show there was an increase in pro-inflammatory cytokines. So there does seem to be some sort of link there. And furthermore, as you've already heard, antidepressants, when given chronically, and only when given chronically, in most cases, will reduce many of these symptoms. So this was a new sort of concept. It's gone further in recent years because we now, of course, can look at the changes in the actual genes, in the immune genes which are associated particularly with depression and which are involved very much in inflammation. And as you can see here, there are a number of specific allelic variants for these pro-inflammatory cytokines which appear to be higher in patients with major depression. And again, there's quite a lot now of molecular biology to support this view that there does appear to be a certain genetic predisposition involving aspects of the pro-inflammatory processes in patients with major depression. This also, linking through to the previous talk, actually one can show that there's also a gene abnormalities involving IDO, the indolamine dioxygenase of the tryptophan kynurenine pathway, and also the serotonin transporter protein. So here we have a big overlap then between the genetic basis and the inflammatory processes and depression. Now, what about the actual changes in patients with major depression? Well, there's a large number of studies. This is one of many of them by Zorilla. Over 40 different immune markers, most of them inflammatory markers, are now related to patients with major depression. And one can find, again, the changes which are associated in the increase in the depressed state very much with the increase in key pro-inflammatory cytokines shown here. And epidemiological studies also show that patients with other major inflammatory conditions such as rheumatoid arthritis, severe psoriasis, and autoimmune diseases, these also have a far higher probability of developing severe depression. So again, we can see the sort of overlap between inflammation, chronic inflammation, and depression. So, oh, sorry, well, we've gone down. So, yeah. Okay, now, the question arises, well, you know, if you look at cytokines, there are large protein molecules, they're bulky molecules. And the question arises, how can these bulky molecules possibly signal what's going on in the brain from the periphery, and vice versa? So how does this all work? Well, there's a number of possibilities. First of all, it's been known for a very long time that in major depression, there is a leaky blood-brain barrier. In other words, large molecules can, in fact, permeate the brain parenchyma from the periphery. And that's where one would certainly start initiating the connection between the peripheral inflammatory processes and the brain. Secondly, we know there are other mechanisms whereby pro-inflammatory cytokines, even in very mild depressive states or non-depressed states, can in fact influence brain function. So what are the consequences then, even of an increase in peripheral cytokines on brain function? We've already heard, of course, about the activation of indoleamine dioxinase and the increase then in the quinolinic acid, which, of course, is an agonist and activates the glutamate system with possible damaging consequences to brain structure. It's been known, of course, for a very, very long time that any form of stress or major psychiatric disorder, such as depression, brings about an activation of the hypothalamic pituitary adrenal axis with a rise in cortisol, which also has consequences not only in terms of the changes in inflammation, but also, of course, in inhibiting the synthesis in the brain of neurotrophic factors, such as brain-derived neurotrophic factors. So here we have a mechanism, a chronic mechanism, whereby the normal repair of damaged brain tissue by neurotrophic factors is in fact impeded by the presence of cortisol. And again, that's part and parcel of chronic major psychiatric disorders. The activation of the glutamate pathway, which we've already heard about, obviously has consequences if this occurs abnormally and excessively in terms of apoptosis and destruction of brain cells. And then we have the changes in monoaminergic and other neurotransmitter function, which is part and parcel of these changes in brain structure and function caused by the previous changes. So we can see how all these things come together. Okay, sorry. What about pro-inflammatory cytokines in depression and the sort of evidence? I've already briefly touched on this, but the most important point is the third point there, dealing with antidepressant treatment. The view which we had a few years ago was this is how antidepressants really work. They work by reducing pro-inflammatory processes within the brain. However, not all antidepressants work. Not all antidepressants work with all patients. And sometimes we've got something like 1/3 of antidepressants that don't seem to work at all in some more severely depressed cases. And so there does appear to be a difference in how the antidepressants actually change and counteract the pro-inflammatory cytokines, which probably accounts for the fact that we do need better antidepressants. So certainly we would argue that pro-inflammatory cytokines contribute to the symptoms of depression, but not all antidepressants that we have necessarily completely attenuate and block and reduce all of the inflammatory processes. If so, we would, I would argue, have pretty perfect drugs, which we do not have. So what's the consequences then of all this in terms of chronic long-term depression? Well, first of all, it's been known for a very long time that there are structural changes within the brain of the patient with major depressive disorder, in the hippocampus, in the amygdala, in the frontal cortex, and so forth. And that there's a reduction in amygdala volume, hippocampal volume, and so forth. This is well established in many, many, many studies now. And now why is that? Well, the possibility is, of course, that in depression there's a production of a whole number of neurotoxic end products. These neurotoxic end products bring about the increased apoptosis and death of brain cells. This is just a sort of a few examples of them. You've heard about the kynurenine pathway, another pathway, the so-called INOS pathway, leading to an excessive production of nitric oxide, which is again very important in terms of lipid peroxidation and so forth. I've already mentioned the HPA pathway with glucocorticoids, and one of the many adverse effects of chronic glucocorticoids is the inhibition of neurotrophic factor synthesis and therefore brain repair, and also we have the activation of cyclooxygenase 2, which we'll hear more about later, leading to the production of prostaglandin E2, which then has quite profound anti-inflammatory effects and effects upon the integrity, particularly of the neuroadrenergic system in the brain. So there are a number of mechanisms which operate as a consequence of the increased low-grade inflammation. And then if we look clinically at the end stage, looking back, what are the consequences of chronic, often life-term, depression when that patient reaches middle-aged or becomes elderly? Again, just summarizing a lot of the evidence, and this was a very, very nice study which has been replicated since, but the first one by Rapp, showing there was a relationship between depression and the density of amyloid plaques in the brain of the patient when they become elderly. In other words, the longer you have been depressed, the more amyloid plaques have in fact accumulated in the brain at the time that you dement. And this appears to be linked very much to whether or not you've been depressed in earlier life. The longer you've been depressed, the more the amyloid plaques and the more likely you are to in fact develop, in this case, Alzheimer's disease, but it would apply right across the board to other types of dementia too. So there does appear to be this sort of link between chronic depression and dementia. And of course there's a whole number of quite brilliant epidemiological studies, mainly conducted in the Netherlands. The big one was the Rotterdam epidemiological study, where they looked at well over 7,000 subjects and looked at the background, the proportion that were depressed, the proportion that developed Alzheimer's and so forth. And basically what they came down to was that those who had suffered chronically from arthritis and therefore had been on anti-inflammatories, it seemed to offer some sort of protection later on against the predisposition to Alzheimer's disease. And then they started looking at the possible explanations for this, which involves, of course, the synthesis, the rate of synthesis of beta amyloid. So again, when we actually look at the drugs we have, we can produce beautiful pathways like this, showing what all our wonderful antidepressants do. And indeed they do have some antidepressant effect, including effects on oxidative stress and so on and so forth, but clearly they are not good enough. Maybe they are not good enough as true anti-inflammatories. And of course this, therefore, when we start sort of looking again at the genes which I've already mentioned, these are the sort of genes that somehow one has to try and influence, and certainly the consequences of the activation of those genes. So maybe the way ahead is to look outside of the conventional approach to antidepressants to drugs which do have a proper anti-inflammatory activity. I'm not going to steal the thunder of Professor Muller, who's done a lot of this very, very fundamental work in the clinical area on COX-2 inhibition and so forth. But this just sort of summarizes sort of some of the evidence that drugs which in their own right are not conventional antidepressants, which in other words do not primarily target monoamines, either serotonin, noradrenaline, or dopamine, nevertheless there's very, very good evidence in clinical studies now that these drugs could have useful antidepressant properties. This is just one of several very good double-blind, placebo-controlled studies showing, of course, the combination in this case of the COX-2 inhibitor celecoxib with sertraline versus placebo versus sertraline, and you can see that there is a big advantage in combining the celecoxib with the sertraline to produce that extra effect in lowering, in fact, the pro-inflammatory status. And so, ladies and gentlemen, just to bring this together, I think the inflammation hypothesis, the macrophage hypothesis, the cytokine hypothesis, explores novel possibilities for treating depression. We have to, as Dr. Myint said, start thinking outside of the very narrow box, which to some extent has been confined, I think, by the drugs we have, which have been produced by the multinational pharmaceutical industry. Everything is serotonin. Serotonin is the answer to all psychiatrists' problems. Unfortunately, we know it's not. So we have to start thinking more biologically and to think, therefore, in terms of other hypotheses. I think the inflammation concept provides this evidence to unify the comorbidity of many of the medical disorders which I have not touched upon. But we have to ask the question, why do the majority of our patients with major depression often die prematurely, maybe 10 years or more prematurely, not from suicide, some do, but most do not. They die from heart disease, from cancers, from the complications of diabetes, etc., etc., etc. And this has nothing to do, one would say, with the underlying pathology of the brain and depression. Of course, if you start looking now globally, as I've tried to present to you, it brings out a totally different approach to why these comorbid conditions occur. So there is this link between chronic depression and also dementia. And this is the growing problem in virtually all most countries of the world, indeed, in the next 10, 20 years. The aging population, increased dementia, and particularly increased Alzheimer's disease, for which at present we have absolutely no effective treatments. So anything we can do then to reduce this in terms of our medication is very important. And we're just arguing now that chronic low-grade inflammation may provide a novel target. I'm not saying it will, I'm saying it may provide a novel target, and that's what I think we have to look for. So with that, Madam Chairman, ladies and gentlemen, thank you for your attention.